ಚೆಕ್ ಮಾಡಿದ್ದೀನಿ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಬೇಕು ಬರುತ್ತೆ ಕರೆಕ್ಟ್
ಎಕ್ಸಿಟ್ ಆಗಬೇಕಷ್ಟು 9 ಜನ ಇದ್ದಾರೆ
ನೀವು ಸ್ಟಾರ್ಟ್ ಮಾಡಿ ಸರ್ ನೀವೇ ಬ್ರೀಫ್ ಆಗಿ ಆಗುತ್ತೆ ಲೈವ್ ಇದೆ ಬರ್ತಿದೆ ಲೈವ್ ಕೇಳಿಸ್ತಿದೆ ಅಲ್ಲ
Good afternoon, friends. I'm Dr. Belliappa. I'm a radiation oncologist at Apollo Hospital. So I have been asked to talk on advanced therapy in oncology practice. So I'm in oncology practice in past 30 years. So many things. When I started my post-graduation way back in 1990s in Kidwai, what we were practicing and what presently we are practicing, so much of changes has happened. And the technology transfers happened and everything is available. Whatever I'm talking is available in India and in your hometown also. So I wanted to talk to you about the advances happened. So I want to start on these topics, what all about understanding the cancer. We should know what is this cancer before we start treating this cancer, and what are the advances happened in the diagnosis of cancer, and what are the advances happened in the treatment of cancer. So understanding cancer, cancer is just like see, all of us have a lifespan. People may live for 80 years or 90 years. That is the lifespan what they have, and every cell in the body has got a lifespan. You know, the RBC has got a lifespan, the WB has got a lifespan, the platelet has got a lifespan, and like the cells on your superficial skin has got a lifespan. So the skin production will be there in the intestine or anywhere, and there will be after a certain time they will deplete. That is, they have a programmed cell death that's called apoptosis. So this balance has to be maintained. The production and the destruction balance has to be maintained. What happens in cancer? This balance gets altered because of cancer causing agent. What are the cancer causing agent? It could be a tobacco or a diet or pollution, or even sometimes even genetics, some transformation could be there. They all may lead into, there is some irritation to the cell, and there may be abnormal production of the cells that may cause increased cell in the blood, that is in the form of leukemia, or it could be a tumor formation, the breast tumor, a lung tumor, or any soft tissue sarcoma. That could be an increased production. So this balance gets altered, and the cell destruction may come down, or the production of the cell may go up. So that's how we can see a tumor. This is how the basics, the balance gets altered because of the cancer causing agent. So what happens is, usually when there is a chronic irritation with the carcinogen, so these normal cells, they turn into hyperplasia, or there could be a mild dysplasia, or it could be a severe dysplasia. And when there is an abnormal growth, then we take a small needle biopsy or a true cut biopsy, and then we diagnose. So how do we diagnose? We compare with a normal cell to an abnormal cell, and we say it is a malignant or not a malignant. So what happens when there is a growth? It can spread in two ways. One is the local spread. You all must be aware, for a cancer we have a crab as a sign. For a cancer we put crab as a sign. That crab can go in any direction. It may go upwards, right, left, or in a different direction it can go, and the cancer also can spread in different directions. So it may cause the cells may infiltrate the local tissue, or it may infiltrate the nearby blood vessels, or it can infiltrate into the nearby lymphatics, and it can go through the lymphatics to the nearby lymph nodes, or if it gets into the bloodstream, it can go into the different organs, like for example, a lung cancer can go into the bone or brain, anywhere it can go into the circulation, it go into the liver or wherever it is. So this is how the cancer spreads. So once we know cancer, suspected cancer, see, the gold standard is like this. We can't you can sit and say, oh, you do this scan, do this treatment. No, this is the gold standard. History and physical examination is a must. So I tell my residents or my consultants, whoever it is, you get up, talk to the patient properly, take the proper history. When the patient enters, you may be knowing this is the symptoms, but you listen to this thing. Every patient will learn something new. So history is very important. Based on the history, we do a physical examination. So any cancer we diagnose in three manners. One is clinical diagnosis, then with the help of imaging, the radiological diagnosis, and the final is the pathological diagnosis. So all three is important in taking a decision on the treatment. So physical examination is very important. Based on that, we ask for the imaging, required images. All patients need not go through every imaging. Based on that, so I will tell you about what are the advances happen in the imaging forefront. We started long back, still we use this in basic X-rays. That has been followed by nowadays has been replaced by this is different kind of CT scans. We have a different slice, 12 slices, 64 slices, like that. We have different generation CT scans are there. In that also we can diagnose this. But what has happened new is the we have the MRI, which has also been used for about say now 15-20 years. What's happened now is the PET scan. The PET scan is it is not it is a functional scan. It will tell us it is a benign tumor. See, there may be a tumor. It may be a breast tumor or anywhere, a meningioma or any tumor anywhere in the body. It could be a benign or a malignant. So this is the functional scan. It will tell us that tumor is malignant or not. For example, a primary tumor, a tongue is there. There may be some lymph node. It could be infectious or it could be a malignant, whether it's gone beyond that area or gone to any other lung or bone or liver metastasis. We can do this. This is the whole body scan. So PET scan has been used for past 10-12 years, but so many things has happened. Advancement has happened in the PET scan also. Usually we do the glucose, that is 18,4-deoxyglucose, that is what we tag the glucose with the radioactive material. So what happens is wherever there is malignancy, there is an increased usage of glucose. So the cancer, when you inject all this glucose which is tagged with the radioactive material, get clogged in that malignant area. Then we do a scan with the PET CT scanner. Then we know it is a malignant. There is a concentration of radioactive material, and we say it is a malignant or not malignant. So there is some different diagnosis, maybe sometime chronic infection like tuberculosis. We have to keep in mind. We may get some positivity there also. For that, there are some new isotopes have come. For example, we have a dotanac, that is gallium-68, that has been used specifically for neuroendocrine tumors. So we can differentiate whether it's a neuroendocrine tumor. So we don't use a regular 18 FDG, we don't use it. Or for prostate, we have previously used to use same FDG for prostate malignancy, but we don't use anymore. We have a specific isotope called PSMA isotope, that's called prostate specific membrane antigen isotope. So like that, we have a choline scan for for certain tumors brain tumors, like that methionine tumors for especially brain tumors. And what happens is when we treat a cancer patient with brain tumor, after some time there is on a CT or MRI, there could be a tumor may be seen. But whether it is a radiation necrosis or a tumor, we have something called a methionine 11C that can differentiate between the radio necrosis and a tumor. So we have a different type of isotopes available now with the PET CT. Previously, all the patients used to go only with 18 FDG, but nowadays we have a different kind of isotopes. This is all the newer isotope which has come, which can use for specific tumor, and we can differentiate. So that is what's happened in the PET CT scanners. So in the PET CT also we have we have a PET MRI. This is also available now in Bangalore. So this is also especially very useful especially in brain tumors. In PET MRI, especially what happens is regularly you use a FDG because there is a increased glucose metabolism in the brain. It may be difficult with the regular PET CT. So PET MRI is more useful, especially in brain tumor related disease. That is, radiological things have come up, so we can, once we have a clinical diagnosis, that followed by a radiological diagnosis, then to confirm what type of tumor is very important. Previously, we used to diagnose this as a malignancy. It's a cancer. For example, I'll just give you a simple example because cancer breast has become a very major problem in Bangalore. Bangalore has become a capital for breast cancer malignancy in women. It's unfortunate, nearly about say 26 to 28%, we get to see in the if you have 100 women cancers, nearly about 25 to 28% is breast cancer. Previously we used to do a true-cut biopsy or a excision biopsy or incision biopsy and see whether it is a cancer or not. That may be a invasive ductal carcinoma or a ductal carcinoma in situ. This is our medullary carcinoma. This is the way we used to diagnose. Now with the modern pathological diagnosis, we are able to say the subtype, whether they are a ER/PR positive or herceptin gene positive or DNA ploidy. We can understand the histology and we can decide how this patient is going to do in the future, whether the patient requires chemotherapy or whether the patient requires hormone therapy with all the immunological studies. Previously, I remember when I was a student, previously what we used to do is all premenopausal patients used to get chemotherapy and postmenopausal women used to get hormone therapy. That was a blind way we used to treat because we didn't have the facilities of immunohistochemistry. We used to sometimes affordable patients, we used to send them to Bombay, and that was very expensive. Now it's available most of the diagnosis center in Bangalore. So we use the immunohistochemistry for most of the tumors, and which will tell us the tissue of origin and so many mutations. All those can be seen. The other one is a genomic study also is coming big way. That also will predict the outcome of a lot of tumors like brain tumors or lung tumor. We can tell the patients are going to do well, and nowadays they do next generation sequencing also. They have been doing it. They are doing like 40 genes or maybe 120 genes or even sometimes 500 genes. They do it, and they'll be able to say this patient may respond to this kind of a specific line of treatment. So sequencing is coming in a very big way. That's what is happening in pathology in managing, which helps us in managing the specific diseases. So coming to the advancement in treating cancer. So usually our motto is mainly to cure the disease. Yes, of course. And what happens is, because many times these cancers are asymptomatic, and especially in intra-abdominal, intrathoracic, most of them sometimes they come in very advanced stages. So sometimes they may be metastatic diseases. So in those cases we may have to give some treatment and prolong the lifespan. And sometimes very advanced, they're bedridden or something. Sometimes those kind of cases we just give a palliative care. What I mean to say, the prolongation of useful life, because see, nowadays the modern technology, the modern chemotherapy and hormone therapy, sometimes even cancers like a lung cancer with EGFR mutation, what I said, if the immunohistochemistry, if you find out, even with EGFR mutation, some of the patients, they live for 5 years, 7 years, even stage 4 cases. For example, cancer of the prostate, cancer of the breast, even with bone metastasis, we have survivors 5 years, 10 years. So it's because most of the cancers that come in geriatric age group. So in these patients, if we are giving a lifespan of other 5 to 10 years, it's a very big achievement. Even so for that purpose, you give up. There are some newer line of treatments have come, and we can control the tumor. It will become like a chronic disease like diabetes, hypertension. We may not be able to cure it. We may be able to control the disease and prolong the lifespan with a good quality of life. So what are the main line of treatment which you are all aware? Mainly surgery, radiotherapy, chemotherapy, hormone therapy, biologic therapy and immunotherapy. In this surgery and radiotherapy, these two treatment is mainly for local control. So, and the chemotherapy, hormone therapy, biological immunotherapy is a systemic therapy. Like, if at all I did mention in my first few slides how the malignancy gets migrates or gets metastasis to the lymph nodal area or even to the different organs. So there the chemotherapy and the hormone therapy come into play. But surgery and radiotherapy comes as a main role in treating the cancer initially and followed by this hormonal therapy. So this is how it is. In certain cases, see the surgeon's role, almost 90% of the cases they have a role, even in maybe starting from biopsy to the removal of the tumor, debulking. I will talk to you about that. And radiotherapy nearly about 70%, somewhere in the middle of the treatment or pre-treatment, post-treatment, there may be a role of a radiotherapy. And chemotherapy, in between after the treatment, the adjuvant treatment or pre-operative chemotherapy. So they all are interconnected. Like it's not that the surgeon has only one role to play in the management. There are, for example, certain malignancies only the medical oncologist has to take care. For example, hematological malignancies like leukemia, lymphomas. Only the myelomas. Usually the medical oncology play a major role. Sometimes the radiation oncologist we play, for example, gynecological and cervical cancers or lung cancers or vocal cord cancers, any head and neck cancers, only without doing any surgery, radically we can do radiotherapy and cure the disease. Otherwise, most of the cancers like the breast cancer, lung cancer, brain tumor, the surgeon operates, he will remove as much as possible, followed by, for the microscopic disease, we deal with radiation and systemic therapy. So I'm not a surgeon, I'm a radiation oncologist. I will just brief you what is the advances have happened in surgical techniques. So mainly the local modality of treatment, it is as I mentioned, it is actually the primary tumor is mostly removed, or if not removed, it can be debulked, especially in brain tumors where the tumor is sitting on some critical organs, and it will reduce the bulk of the most of the disease. And if any metastatic disease also, for example, breast axillary metastasis has been removed, or in case of any oncological emergencies like fracture, they may have to fix those fracture. So they have a role in mainly to remove the tumor, and even palliation also they have a role to play. So usually what it used to happen, usually it used to be an open surgery which has been practiced for centuries, that was replaced by a laparoscopic surgery. Now laparoscopic is still practiced in certain areas, but now it's been replaced by robotic surgery. We have in Apollo also we have a robotic surgery. So I'll just tell you about this robotic surgery. This is a robot which sitting on the console, they can move the arms, and they get a very good visibility. What has been told is nearly about 12 to 15 magnification factor they met with a three-dimensional picture they give, so that get a very good visibility, and the blood loss is very less, and the entry points will be very few. So within about 3 to 4 days the patient can go home. So the blood loss is less, the hospital stay will be less, so the clearance is much better, they claim, so that because they have a very good visibility in the area of operable. So this is what we call Da Vinci, the new robotic surgical system we have procured. There are a few centers also to have, but we have in Apollo also, and we've been using, this has been used by most of the surgeon. A neurosurgeon uses it, a thoracic surgeon uses it, our colon surgeon also, even head and neck surgeon, when some of them they use in a different route to a neck dissection where the scar is not visible. So most of the areas the robot is been used for surgical procedures. So this is the latest thing which has come into practice. Coming to my specialty, so again as I did mention, radiation is mainly for a local control. So where we control the disease locally, and we use different techniques. What it used to be before and what we are doing is entirely different. We control the primary, as I did mention, certain type of a tongue tumor or a vocal cord or a base tongue or any head and neck malignancies. We radically treat with radiation, or sometime like gynecologic tumor, again we treat with radically with radiation, or different ways which I will mention in my next few slides, or sometime we use radiation as a palliation also. I'd like to spend some time, maybe a couple of slides about little bit misconceptions about radiation, because a lot of people, I think the oncologists may be aware of it, but for general clinicians, I want to tell you about how the radiation acts. See, with radiation, we don't burn any tissue like a cautery or laser. See, radiation, we have about nearly 79 to 80% water. When you give radiation, the radiation ionizes the water molecule into water and OH, that is H2O, becoming H, two H's and OH radical. This OH radical are toxic to the DNA of the cell. So DNA, we have the adenine, thymine, cytosine, guanine, the DNA strands have. This OH radical goes and sits on the bases, adenine, thymine, that prevent the mother cell from dividing into a daughter cell. This is how the radiation stops the mother cell dividing into daughter cells. This is how we stop the cells from further multiplying. So this can happen in the field, not only to the malignant cell, it can happen even to the normal cell also. That's why you don't give the radiation in a single sitting. So what we do is we give today one fraction, we give a 24 hours gap, so that what happens, the repair of the normal cell happens. So the normal cells has got a capacity because they have a normal DNA, so they have a capacity to repair compared to abnormal DNA. So this is the reason we give radiation in a much a stack with multiple fraction. It may go up to 4 to 6 weeks depending on the type of histology. And oxygen also is very much required for the tumor kill. So what happens when the tumor shrinks, the blood vessel which is closer to the tumor, there is a diffusion of oxygen, so it gets reoxygenated. So in the next fraction, the next sitting, there is a much more kill of the malignant cells. And cells, the radiation doesn't kill cells cells have a different cell cycle. We have a G2 phase and mitotic phase. These are the phases the cell gets killed. All phases, the S phases and G0, G2 phases, G phases, they don't get killed. So the late G2 phase or a mitotic phase, this is where the cell gets killed. And repopulation is also required so that the morbidity, the late complication is very minimal. This is something about the radiobiology of it. And one word on the unit of radiation. We have a different units for measuring for centimeter, meter, and for weight, pounds and kgs. The unit of radiation we call it as centigrade. I think your older books may be mentioning rad. 1 rad is equal to 1 centigrade, or 100 centigrades 1 gray. So usually nowadays we all the books and we talk in gray. So this is one slide I thought I will share with it. And this is one slide to show the histology is very important. We have a squamous cell carcinoma, adenocarcinoma, dysgerminoma, seminoma, Hodgkin's. The histology is very important for radiation oncology also, because the doses vary from different histology. For example, a dysgerminoma or a testicular tumor of a dysgerminoma or a seminoma, a dose of 2500 centigrade is adequate for a tumor kill. For a lymphoma, 3500 to 4000 centigrade is enough for a tumor kill. For a squamous cell carcinoma, we need about say 6000 to 7000 centigrade. Adenocarcinoma again around 7000 to 8000 centigrade. So the histology is very important. So this is a slide to show histology is very important in knowing the dosage for what malignancy, what dose to be given. So what are the things? How do we treat cancers? Usually we treat by two means. One is teletherapy and brachytherapy. Both are the tele means in telescope. From far we treat. The patient may lie down on the couch. The machine emits radiation from far, and we treat as a teletherapy. Brachy means near therapy. Brachy in Greek means near, where we put the radioactive metal inside the body and treat. That is brachytherapy. So what are the machines we use? Previously we used to telecobalt. Now what is the advances is the linear accelerator. Linear accelerators come almost about say 20 years back, but in the linear accelerator, different type of energies and different types of multi-leaf collimators technologies have come. What the motto behind is that we give maximum dose to the tumor and we have to respect the normal tissue. So the tumor gets the maximum dose. When you get the maximum dose of tumor, we get a better tumor kill and the outcome is much better. So in the same bargain, like we try to prevent the normal cells, so we have a very minimal damage to normal cells, so the morbidity or the late sequelae, late complications are very minimal. So linear accelerator, we have a new linear accelerator called a true beam, which has got a multiple leaves, micro multi leaves, so that we can pinpoint, and very small tumors also can be treated with that. And gamma knife, which is available in Bangalore, we have a gamma knife, cyber knife, tomotherapy and proton therapy. Proton therapy is actually a new, is only one in the whole of India. That is a particulate therapy which procured in our Apollo Center in Chennai. So this is how, like the left side is the telecobalt, which is no more used, or very few centers in India they've been using it. This has been replaced. You can see the picture which we have a linear accelerator, a true beam linear accelerator. It emits X-rays. The same X-ray what used for diagnostic X-ray, but it is a high energy. What usually used for diagnostic X-ray, you must be aware, 100 kV X-rays we use. For a CT scanner we use 125 kilovolts, but this treatment true beam, it emits anything between around 600 to 1000 kilovolts of X-rays. That is high energy X-rays, precise, millimeter wise, sub-millimeter wise precise. We can treat where to treat, and we decide and we treat this patients. So some other equipment is used for treatment purposes: a gamma knife, a tomotherapy, and a cyber knife. And with the what we use in our Apollo here is we have a stereotactic. We have a brain lab software where we use the same true beam and treat very precisely to different areas where we have a small tumor without any metastasis. This is mainly mostly we have been using for any head and neck malignancy, both malignant as well as benign. Like benign, where we give radiation is for acoustic neuroma, pituitary adenomas, AV malformation. These are the areas where even the benign diseases we give high dose one-shot radiation, where we can get get away from surgery and we can treat the tumor. So before treating, we want to make sure the position is almost accurate for the simulation as well as for treatment purpose. So on the left side I can show you this is actually a specific mask, that is immobilization mask we do first. Once we do the mask, with the mask we do a CT scanner. CT scan is done not for diagnosis purpose, we do for mapping purpose. Where to treat we map out, and more importantly we have to map out where not to treat. For example, left side you can see the colored ones which have all been mapped out where not to treat. The other one is the tumor, red one is where the tumor to be treated. So we map out the area where to treat, where not to treat. That goes to our computerized planning system, where the mission data will be there. It will decide from which direction you give treatment, that area will get treated, the other area can be avoided from the field of radiation. So this is what we're going to do with this thing. And with for a tumor small tumors, we give a single sitting and the patient can go home after the treatment. So we'll be able to treat this SRS, SRT, that is stereotactic radiosurgery or stereotactic radiotherapy, the single sitting or maximum 3 or 5 sitting. We can finish the radical treatment and we can send the patient home. So that facility is available. We use see on the right side you can see there are 2 X-rays, this is called an extract. We track the tumor see, we can plan everything, looks very nice on the computer, but on the table are we treating that point is very important. So we put it with the same, or if with the mask, and we do a CT simulation, a CT scanner again, the onboard CT, and we make sure the planned CT and the onboard CT matches. And during the treatment we have to track this thing, so we use this extract and we track the tumor and treat the tumor. We make sure that treatment is going to the exact that particular point not millimeter, sub-millimeter wise precise. So this is some of the areas you can see on the left side. On the top, the multiple brain, only that area can be treated. On the right, we have the lung lesion. You can see the normal lung has been spared. On the left bottom, you can see the liver lesion. Only the liver lesion can be, and we can minimize the dose to normal liver. And spine, if you see, like, you know, both the sides, we have the kidneys. We can minimize the dose to very minimal dose to the kidneys, and we can treat only the spinal cord. This is the advantage of this brain lab SRSSRT technique. I was mentioning, like, now we are talking about the proton therapy. See, till now what I was talking about, we are treating with X-rays, but they are ionizing radiation, like, you know, it's non-particulated. Now this here in proton we use a particulate therapy that's got a specific property, like, you know, X-rays, when we start, if it enters the body, exits from other side. But here we can track the tumor. We want to, like, you know, treat only 5 centimeter like a deep lesion. We can treat only that lesion. We can avoid the radiation to the other part. This is an advantage of proton therapy, especially very largely used in brain tumor and nasopharyngeal carcinoma and pediatric tumors. So this is what we have procured about a year back. It has been commissioned in Apollo, Chennai. This is the one it was commissioned. I mean, I had this opportunity to be there during the commissioning of this machine, the proton therapy, one of its kind in Southeast Asia. And you can see I have put a, like, you know, comparison between IMRT and what we treat with the X-rays and with the proton. See, the proton on the right side, like, you know, you can see the blue thing on the left side. Some scattered radiation will be going to certain normal tissue, but we should know how much is the limitation. But with the proton, we can be focused only to the tumor area, and you can avoid the normal tissue even to the maximum. This is on the left side, you have the proton, and the right side IMRT. Even though, like, you know, maybe around, say, about 20-25% may go to the normal tissue, but 100% goes to the even in the IMRT. But here the 20-25% is in and around the tumor tissue. This is an advantage, but it is a very expensive unit. The machine costs almost about 600 odd crores. The treatment also expensive though. The second way of treating malignancy is brachytherapy. Brachytherapy, we, as I did mention, it is putting the radioactive material inside the body and treating. We usually use it from head and neck, like, you know, for nasopharyngeal lesions, and we've been using for tongue malignancies. We're putting wires into the tongue and we are treating. And esophageal malignancy we've been treating. Breast implants we've been doing, and we've been doing for gynae malignancies. We have something called the regular intracavitary or a perineal template we've been using. So the advantage is here the applicators inside the tumor, and we can give maximum dose to the tumor, and we can minimize the dose to the normal tissue. So we have previously we used to do manual afterloading. Nowadays we have all remote afterloading. The left machine which shows is a remote after machine. We do the application, everything in the theater, operation theater, and the empty applicator you can see on the right is all the applicator for different tumors, and through the applicator we connect it and come outside, and we switch on the machine, and the machine will take the radioactive isotope inside the body and we treat. So that way we can give very high dose radiation to those areas of interest and very minimal dose to the normal tissue. So when you give radiation, I did mention in a curative radical treatment, in a curative treatment, or when there is a very advanced, you can palliative for pain reduction, or sometime for rectal cases and all those things we give the pre-operative give. We debulk or shrink the tumor and we treat. Post-operative, most of the cases we treat post-operative therapy. Some head and neck and gynecological cervical cancer we combine chemotherapy and radiotherapy. So we do treat as a combination treatment, and certain cases, like, you know, we give prophylactic radiation to the brain. That is, like, you know, as a prophylaxis, because sometimes chemotherapy don't cross the blood-brain barrier, or some small cell tumors of the lung. There could be a lot of recurrence in the brain, so as a prophylaxis we give short course of radiation to the brain also. So brachytherapy I did mention, intracavitary, interstitial, intraluminal, which the different areas we treat, and these are the areas where you use brachytherapy. So this is what is my specialty, which I've been practicing past 30 years, which I'm enjoying. I had privilege of getting trained in even US, Germany, and in France for this specialty. So what I learned is like the techniques, but we are also, which I can proudly tell you, what all has been taught in this thing, what all the techniques and schedules, everything even is available in India, and most of us are practicing even in India, in your hometown also. Coming to the other systemic therapy, is mainly chemotherapy, hormonal therapy, or targeted or biological therapy and immune therapy. So all these things, some of them are newer things, are very expensive, but it is available in Bangalore or in any part of India also. See, the technology transfer really helped us to get the technology back to India, and that way we're able to give the treatment to the patient to their for their maximum benefit. So, like the role of chemotherapy is mainly for when there is a disease which has gone beyond the primary to the systemic area. For example, breast, there is a large tumor which is the axial lymph node status is there. So definitely there will be, see, once the disease goes to the armpit, that is the axillary nodal involvement, we consider as a systemic disease. So not only with the local treatment, like with the surgery and radiotherapy, chemotherapy is mandatory. I'm just giving an example like that. So many tumors, chemotherapy has got a major role to play, and I think one of these days our medical oncologist will come and address you regarding these things. And sometime, even though primary is removed and the PET scan doesn't show any disease anywhere else, we give chemotherapy as an adjuvant treatment. So a certain hematological malignancy, it becomes the primary line of treatment, like for example, leukemia, lymphomas, myelomas, where chemotherapy is a primary line of treatment. So hormone therapy, mainly certain malignancies are hormone dependent, especially breast cancer and prostate cancer. So different kinds of hormones have come, injectables, like tablet form, they have come. So with that, even I did mention prior, even stage 4 also with the hormone management, like prostate with the bone metastasis, the breast with bone metastasis, we can control the disease, we can give a very long, very symptom-free life, and we can give a very good quality of life. So stage 4, I just request all all the clinician colleagues, don't give up. Every case we can manage. The technology is available, the therapy is available. I think you have to take an oncology opinion and give the best to the patient. So the monoclonal antibodies come in a very big way, that has been used for cancer management, and especially sometime different receptors we have found, like what receptors are activating the cell. So there are drugs which can block this receptors, and we can control the tumor. And one more, biological therapies, it can normalize the vasculature of the tumor cells, and the drug delivery can, and there is a tumor control. It's called anti-VEGF, that is called bevacizumab. That's what they say. Avastin is available. It's been used in most of the tumors, and they've seen very good results. And nowadays, for most of tumors, if every treatment fails, they have been using this immunotherapy, this nivolumab and pembrolizumab. This has been used for most of the tumors. Even they have failed to so many types of the first line, second line chemotherapy. They have been trying this thing that has shown good results, and they're able to control the tumor to a certain extent. The body also helps in fighting the tumor, and they have come with some good results. These are the two gentlemen, James Allison and Tosaku Honojo. They are last year, I think, they have been awarded with the Nobel Prize for bringing immunotherapy for our clinical practice. I think this must be my last slide. Thank you for hearing. So what I want to tell you, a person who has got a cancer, they have a choice now. It's not like they can do a breast conserving surgery or organ conserving surgery. For ortho-oncology, they can conserve the organ, they don't have to do a total removal of the organ. If they have osteosarcoma, they give neoadjuvant chemotherapy, shrink the tumor. They do a knee replacement without doing any doing an amputation, and patient can come back to this thing. I have some of my colleagues or some friends who've been treated way back when I was in Manipal Hospital. I remember way back in 1996, the patient still doing well with the organ conservation. So things have changed. Oncology, what it was maybe 20 years back or 10 years back, it's not the same. Science keeps progressing, and it's I mean, even attribute towards oncological management. Thank you for your patient hearing.